The one thing that comes into question is what do you do with high-risk based patients who have high-risk based disease, both in terms of transplant and also in terms of maintenance. In the US, we did a randomized trial looking at a single versus tandem autologous transplant, and there was no difference in terms of single versus tandem transplant in the US study, and that was the Stamina trial. In a European trial, the EMN02 trial, where they used a bortezomib-based induction therapy with cyclophosphamide and dexamethasone, those patients who received induction followed by tandem autologous transplant did better than those who received induction followed by single autologous transplant. And really the people who did the best were those who had high-risk disease. So if you had high-risk disease, it was better in the European data set to get a tandem transplant versus a single autologous transplant. Now, the difference between the US and the European study is in the European study, they didn't use an IMiD as initial induction therapy with bortezomib. In the US, almost all patients get an IMiD plus a proteasome inhibitor as induction therapy. So in fact, we believe in the US that as long as you get an IMiD and a proteasome inhibitor as induction, you probably only need a single autologous transplant after that, even if you have high-risk disease. In terms of maintenance, there was a randomized trial from the UK, a large UK study, that showed that actually there was a benefit to lenalidomide maintenance, even if you had high-risk disease. The CLGB study in the US did not show a benefit in the high-risk population. But that said, I think all of us believe that lenalidomide is efficacious in patients that have high-risk disease. But in fact, what we do is we use lenalidomide and bortezomib as maintenance therapy for patients that have high-risk disease.